Every total hip replacement is a little different. Anatomy, physiology, history, and the events leading up to arthritic change are all unique to the individual. This specific discussion will focus on the management of obstacles in the femoral canal. It turns out that some patients present with an additional history of trauma, hip fracture, or some type of injury, now with associated plates, screws, and hardware that block the actual hip replacement. Others present with an actual biologic abnormality that significantly increases the architectural and procedural challenges of hip replacement. So we'll talk about both those issues, external and internal obstacles, and how we manage them. So there are two main types of external hardware problems. This is the most common type. This patient, we can see, has two screws running across an old femoral neck fracture site. Now, fortunately, the bone in the femoral neck fracture is healed. Unfortunately, the patient has developed a post-traumatic osteonecrosis. We can see this devascularized zone. The bone has actually died. So this patient is a good candidate for a hip replacement. But before we proceed, we have to manage this existing hardware. And we'll need to know three things. One, the manufacturer, so that we have the appropriate tools to remove these screws. Number two, the approach. The hip replacement goes in this way. These screws have to come out from this direction. And then number three, the templating and the sizing so that we can get an appropriate fit and fill of our stem within the canal. And then that is how we get from these two screws blocking the implant, the planning, and finally to the implementation and the execution. For those of you who are interested in a more specific deep dive in the treatment of salvage of femoral neck fractures, I would refer you to this article published in the Hip and Pelvis Journal. We'll talk about the next common example. The next most common example of external hardware that blocks a hip replacement occurs in patients with a history of an endotrachenteric hip fracture. Now, previously we saw a patient with two screws with a femoral neck fracture. This one is a little bit further down the canal. It's called an intertroke fracture, and it's treated with more aggressive hardware. It's treated with a side plate, a lag screw that goes into the femoral head, and multiple screws across the shaft to stabilize this zone. Now, again, fortunately, this fracture is healed. Unfortunately, this hip has become arthritic. The prior patient developed necrosis. This is what's called post-traumatic arthritis. But as we proceed with templating, we can see that the plate and the screws clearly block the path of a femoral stem. And so the same three steps, we need to identify the manufacturer. Several manufacturers make different side plates and hip screws. We need the right tools. Number two, we have to identify the approach. This one is a little bit more challenging. This plate has been in for years, and we can see areas of bone overgrowth. So areas of the plate will be buried underneath the bone. These screws will be removed. This plate will come off, and then the lag screw will come off. Once this hardware is removed and the incision is closed, we'll then make a separate incision up here for our formal hip replacement so that we can place our stem down the canal. The third major obstacle is organic or biological. And rather than having mechanical issues like a plate and screws, there is an internal biologic obstacle that blocks the path of a potential stem. These are a little bit more subtle, but they're actually more complex because, as you can see, they block the internal canal. And I'll show you how we manage this. This lateral view really highlights this blockage right there. And again, this is pretty far down the canal. We'll be working through an opening here, and so we won't be able to see this. So we'll need to use fluoroscopy, which is real-time imaging. And then we will send a series of drills down to that defect and gradually open it up using successively larger drills. Once we've drilled past this, we'll send a guide wire down and then use reamers to open up this canal so that we can obtain later free passage to plan for the eventual femoral stem. Okay, let's just take a little bit of a look dynamically of how a hip replacement works and how we manage these obstacles. So for hip replacement, we have the acetabulum and we have the femur. right? But we're going to focus on how we manage obstacles here. So this patient, prior fracture along the femoral neck, now with an arthritic head. But we're trying to deal with that obstacle that's deep in the canal. Now, we're not going to be able to see where that obstacle is. We can only infer its position from the x-rays. And so what we'll do is we'll remove the femoral head, which then exposes this canal. And deep within this canal is the obstacle. The problem is that obstacle blocks this stem from going in. It'll stop here. And so what we'll need to do is we'll need to take special tools that allow us to drill past that hole. And when we do that, we'll then look at the x-ray in two planes to make sure that we are drilling down the hole and not outside the cortex of the bone. Once we drill past that and clean up the canal, then we will have created a safe pathway for the stem to fully enter. So again, these types of abnormalities are a little bit more subtle, but they're actually much more challenging. So again, we see the defect here, and then when we do our templating, we can see that it blocks it. If the defect was down here in the bone, it wouldn't have been an issue, but it's right in the path of the stem. And so it will come from above, drill it out, ream out the canal, free up both sides so that we can get our templated fit of our femoral stem. So this is a complex topic, but as a quick review, there are two types of obstacles in the femoral canal. There are external mechanical obstacles, and then there are internal biologic. For external, you need three things. One, the manufacturer, so that you can have appropriate instrumentation. Number two, the approach, so you know how you will retrieve the hardware prior to the hip replacement. And then three, the templating, so you know where and how to position your femoral stem. The internal and the biologic are a little bit more complex. You'll often need adjunctive imaging, and you'll need special tools that allow you to gain deep access into the canal to bypass the obstacle. Thank you very much.